طيب السلام عليكم. بنرحب الليلة بدكتورة سارة. سارة is a medical residence. أنا نسيت اسم المستشفى in hospital in UK. نسيت الاسم سوري. صوتك ما واضح يا سارة.
أيوة أنا سارة عثمان. I am a medical registrar in University Hospital of Plymouth.
Okay, thank you يا سارة. سارة كانت عملت الكورس حق الكلينيكال اوديت في تقريبا ماي ولا ابريل؟
أيوة
ماي. وكانت من الناس اللي هم ما شاء الله بسرعة كان عندها audit topic في بالها في during الكورس، كانت بادية تشتغل عليهم في أثناء الكورس، فهسي وصلت المرحلة بتاعت الفيدباك. she's going to present this audit tomorrow ولا متى؟ الأسبوع الجاي تقريبا.
أيوة الأسبوع الجاي إن شاء الله
في المستشفى إن شاء الله.
أيوة
حبينا نعمل له عرض هنا قبل البرزنتيشن والفيدباك، وبعد ذاك ستيل ممكن تجي راجعة تاني نعمل يعني زي supplementary بالفيدباك والimplementation الري-audit. طيب floor is yours سارة. just say next. أنا بغير السلايدز.
Okay. Good evening everyone. I have started this clinical audit, which we are in general medical department. We are mainly interested to know how we are sticking to the standards by prescribing the ferric carboxymaltose, which was IV ion. Okay. Next, please, Asma. Yeah. So I have started with the background. First, the iron deficiency anemia is the most common cause of anemia. Okay, it is affecting around 500 million people worldwide. And the iron deficiency anemia, it is a problem in developing country. But as the same thing, also in developed country, the percentage reaches about 2 to 5%, mainly in the adult men and postmenopausal women. And it is the reason for 4 to 13% of referral to gastroenterologist. During the childbearing age, there is a high incidence of iron deficiency anemia in women because they have more losses, menstruation, pregnancy. Okay, so in this age group, it is common to have an iron deficiency anemia. Okay, so here it shows that the burden of iron deficiency anemia. So it showed that because here in United Kingdom we have old population, okay, which are fragile. Okay, so the target now is the moment to rapid correction of this anemia. It will be the target because it will decrease their morbidity and mortality and their quality of life. Next, please. Okay, so I think this is by mistake, the slide. Okay, so what I have did to try to give overview of different guidelines in my clinical audit. I try to measure our clinical practice in our medical ward with the standard, which is the hospital guideline. Okay, but in our departments, they are more interested to know about they want to know more about the other guidelines. Okay, so I have mainly talk about NICE guidelines. Okay, and the NICE guidelines, it showed that we need first, if you are suspecting iron deficiency anemia, to do full blood count, and you will find low hemoglobin, okay, and low MCV, which is less than 95. When you find that there is low MCV, then you have to go to ferritin level, okay, and they put the cutoff of 30 microgram per liter confirms that if it is less than it confirms that there is iron deficiency anemia, okay, and then if you is still on doubt, they have they are started treatment, but the treatment will be maybe just for the childbearing age and in the younger population. For both menopausal women and for older age, we are not given ever trial of this replacement. Okay. Then you have to check B12 and okay, B12 and folate. Okay. Then I have asthma, please. The second one, please. Next. Then I have look at the BSH, the British Society of Hepatology. They have a nice diagram how we are diagnosed as iron deficiency anemia, and what is the important investigation needed. Next, please, Asma. Okay, so they are mainly here depend on the full blood count. They need to look at the CRP, because the CRP, it means that there is inflammation, and you know that ferritin is the acute phase protein, so it also will be high in inflammatory process. And most of the patients, they are coming in with inflammation and sepsis, and in other comorbidity we have usual high ferritin, okay, in the CKD, heart failure. So the ferritin is not alone will be important, the level, okay. So we have to explain the level of ferritin in the right context, okay. No need about the detail. That is the guidelines. So just we are opening and we are following what is there for the workup. Next, please. Okay, so I should not add these slides, guys, but because of just the knowledge of in the department, they want to know that what will be the guidelines for this chronic kidney disease, and here that the ferritin and the transferrin saturation is not sorry again. So the serum ferritin and transferrin saturation, they are not recommended for iron deficiency anemia in this population. Okay, so they are depending on the blood cells marker, which something called the reticulocyte hemoglobin equivalent and the reticulocyte hemoglobin content. That will be better. Okay, if they're available is okay. If not, they have given that to give the transferrin saturation less than 20 and ferritin level less than 100, because in the NICE guidelines they would cut off of circuit. So you see now in the CKD they need 100. 100 will be normal for them. Okay. Next slide, please. Okay, so the management of iron deficiency, iron preparation. Okay, next please, Asma. Either oral or IV, and it is the preparation for the iron different preparation: ferrous, fumarate, gluconate, sulfate, and ferrous sulfate. Yeah, was different. This is the content of the iron in each preparation. Okay, next please. Okay, so how we have to monitor the response of the iron treatment? So usually we are measuring the hemoglobin after within 4 weeks after the supplementation. Okay, it should be that the hemoglobin should be rise up by 20 grams per liter in 1 month. If we are given the patient IV iron like Ferinjet, it should be given the full dose, because the full dose cannot be given at one time. So now we are talking about the main our drug. Okay, the ferric carboxymaltose. Next, please. Okay, so why we are about the cost of ferrous carboxymaltose, because here they are more concerned about the cost, because the resources are very limited and they want it to be what I have to say, that to be in its right place. Okay, so I will give you estimation how much is this drug. Okay, next please, Asma. Yes, so the 500 milligram vial, it is 100 pound. So and the 1000, it is 140. Okay, so that is mean that is very expensive drug. We have to be cautious when we are prescribed this medication, because if it is unnecessary to give this medication, you are wasting the resources, which is unacceptable. Next, please, Asma. So the indication for pharyngeal, okay, according to our guidelines in the hospital, when the oral preparation are ineffective, that is mainly in the patient who are like malabsorption, or they cannot absorb well. It's heart failure because they have congestion in their bowels, and the people with inflammatory bowel disease. Okay, and the other thing, when I cannot use oral preparation, the people who have any problem in the swallowing, and if we need to have rapid delivery of iron, and we are mainly here concerned about heart failure and CKD patient. There is no actual emergency to give iron rapidly unless that unless the patient or there is no availability of blood product. And this here in UK, Jehovah Witness, because they are refusing bloods. So you are giving here to give iron very quickly is mandatory. So to diagnose the iron deficiency anemia should be, you have a criteria to diagnose it. When I have not to use this patient, either to be not to use this pharyngeal, if there is a patient have any sensitivity to pharyngeal or other iron product, IV iron product, or if the anemia is not contribute to iron deficiency anemia, like thalassemia, evidence of iron overload or disturbance in the utilization of the iron. So it means like hemochromatosis, like this. So our aim and objective of the audit, okay, so we need to compare the current practice of pharyngeal to the standard, which is our trust guideline or hospital guideline. So we have points. We need safe prescription. What is mean by safe prescription? It means that I have to prescribe according to the indication as per trust guideline, and I have to give the accurate calculation of the right dose according to the patient weight, hemoglobin level, and to be given in the right duration and volume. And I have to monitor for serious side effect during administration and cost-efficient practice. That is, well, when I have talk about the cost, that it means that when you are looking at the cost, it is this behavior like cost-efficient practice. Next, please. Okay. So I will go quickly through the standard which we are doing. So we have standards in our hospital to give ferrous carboxymaltose. The first investigation I have to have iron deficiency anemia, and here in our guidelines that we need a ferritin less than 30 or ferritin more than 13 nanogram per liter when the MCHR, which is the content of the iron in reticulocyte, less than 27, and the transferrin saturation less than 16. Okay, so this is the laboratory one. The other thing that by patient factor, I have to check how the patient are tolerable to iron. And the another thing, we concentrate in both these populations, the CKD and heart failure, where this population need, we can say that they need rapid iron replacement. Next, please. Okay. So here the some study, I am sorry because I am at some study every now and then, but because they are interested to know what is what will be the evidence to use it in heart failure. So this is like a systematic review and meta-analysis. It showed that the ferrous carboxymaltose reduced heart failure hospitalization and cardiovascular hospitalization with no beneficial effect on all cause and cardiovascular mortality in iron deficient heart failure patients. So this finding reinforced the role of pharyngeal as therapeutic option in heart failure patients. So when we are using this one, we have a study, we have a the maximum evidence, the systematic review and meta-analysis to use it in heart failure. Next, please. And as I have told earlier, that we have a frail patient, all patient. Okay, so this also another systematic review was done 2017. It showed that this all frail patient, they take benefit more from the IV ion, and there is different formulation, so that we can say that it is better to, because they are old, they have problem with absorption, and they have comorbidities. So when we are using in this frail population, we have evidence to do this one. Next, please. Okay, so here's the dose. No need to know about the details, but the dose, it depends on the body weight. So we have to weigh the patient, and maximum we have to give like 1 gram per week. So here is differently according to the hemoglobin level and according to the weight. You can decide which dose. You calculate the full dose. Okay, for example, if the patient had hemoglobin less than 10 and he is less than 70 kg, so it will be the total dose 1,500. So, but we cannot give this as a one dose. We need to divide it into doses. Okay. And the heart failure, they have different dosing, which is not, we are not usually concentrate about it, but good to know about that the heart failure, they have a different, they are not the usual one in replacement of the ion. Next, please. In the CKD, it will be the same. It depends on the body weight and the hematinics of the patient. The third thing, because the first standard, the laboratory test, the second standard for us, the patient factor, and then the drug factor. So we are measuring how we are documenting about the importance of the weight, documentation of the weight, calculation and documentation of the full dose, and the amount of the first dose should not exceed 1 gram, and the duration of administration, because it gives that the duration depends on the volume. So we have a standard. Each volume needs to be given in each duration, and we need the monitoring, okay, during administration. And we are also looking for the recommendation of the second dose. Usually they give the recommendation in our trust to be given minimum 1 week. Next, please. Okay, so here's the qualitative and quantitative composition of the medication. Just because you see it is not important, but it shows you that if you have to calculate the total dose or the need of the ion, it depends. For example, 1 ml, how much ion it can give. So it is not that important, but it's important to give you the calculation of the full dose. Next, please. Here's the administration. Okay, so the administration, it should be given with normal saline only. And we have to be careful because it contains about 5.5 milligram and diluted sodium, so it is high sodium content. Another thing, we are usually give this medication, for example, this 1 gram, we are diluted with 250 ml normal saline. But in the patient who are overloaded, we have to be careful about this. It can be given undiluted. But the issue that the hypersensitivity reaction and side effect will be maximum. And one thing also, that when you are giving this medication, you should stop oral preparation. We have found that in our practice that we are given the IV and continuously the second day they are given oral, which will which this will affect the absorption of pharyngeect. And this is here's the volume and the administration time. Okay, so I have to put into consideration and try to measure how we are prescribing this drug. Next, please. Okay, so the monitor, we have to monitor the sign of hypersensitivity reaction, which can occur in the first 30 minutes of administration. That is why it should be given when there is a staff, all the staff are around merely morning time, not at night, and when they are trained, because they can deal with hypersensitivity reaction, which it is very, very dangerous. And another thing that we have to also think about hypophosphatemia osteomalacia, which can happen frequently with frequent administration, and the issue of infection. Okay, so the patient, if he's acutely ill or had a chronic infection or asthma or eczema, I have to be cautious about giving the medication in this context. Next, please. Here, just to, because we never have any case in our ward where there is hypersensitivity reaction or extravasation. So just this is the photo how it helped, yeah, to see how the extravasation look like. Next, please. So the method, what I have did to the method for, I use for the data source, I have talked with the pharmacist with checking and dispensing an administration record. So they have like dispensing and administration record. So we have take all the name of the patient and the file number. So we have access in our electronic system, and we have collect all the laboratory tests and everything. So it is mainly from the electronic system. We didn't look at any note, or we didn't see any patient. So all these are retrospectively. And the sampling, we take all the patients who admitted and prescribe pharyngeal during admission in our medical ward from February to May 2022. And the method of data collection, we have a checklist, and the data analysis is mainly prescriptive analysis. Next, please. Asma, I think I have shared with you the checklist. If you can share it, please. The checklist which I have sent to you. Yeah, that is the checklist. That is the test for list. We take the hospital number, the gender of the patient, and the weight, and the investigation needed, and yeah. So it is mainly the three category or three factors: the drug factor, the patient factor, and the laboratory investigation. So that is my checklist, which we have used to do our, or to run our audit. Thank you, Asma. Yeah, thank you. Next, please. Okay. the conclusion, we found that how we are sticking to the standard, okay, which is 100%, we found that in the term of wet documentation, usually we are doing good, 81.25, which is good, okay. And about diagnosis of anemia, okay, we are okay about it, okay, we have nothing to do, it is green. And the ferritin, we are ordering the ferritin, but the issue that all the ferritin we have collected, we're ordering, but most of them, the ferritin are very high, which is less than, which we didn't find anyone who have ferritin less than 13. But we, as investigation, we are requesting. Regarding the MCHR, which is the content of hemoglobin in the retics, okay, we found that we are very poor in this part, so only 6.2. Sorry guys, I think I forget that I didn't tell you that I have 32 patients in this period. Which I have collected all this information. I am doing calculation for the 32 patients. Regarding transferrin saturation, we are doing good, 83.3. Regarding GI intolerance, we find that we are prescribing we are prescribing for the 28.1 only. So it means that we are not checking the tolerability to oral ion. So we have to check this one. And rapid ion delivery, we have found that we are doing 77.2. And the documentation of full pharyngeal dose, we find that all of our colleagues, they are prescribing just the first dose. No one gives the full calculation, which is important because the patient, if didn't receive the full dose, it means that you are failing his treatment. So that will be our recommendation later on. But what is good, we found that we are not exceeding the maximum level, and this may be because it is controlled by the pharmacist. So we are obligated to do so. And the duration, we found that we are stick to the duration. And the monitor, we are monitoring the patient, but the issue that no documented allergy at the moment to give percent. Recommendation for the second dose, we never see any of us. He is talking about when will be the second dose. So the patient, he will get his maximum dose, which will fulfill his storage, and after that need to be given on maintenance for 2 to 3 months later. Next, please. So when we are coming to root cause analysis, we are calculating. Maybe I need the help of asthma for the problems we are thinking about. So if we have talked about the laboratory test, we have found that we have a problem in the awareness about how to interpretation of the RBC's indices and the ferritin level and MCHR and the ion study preparation. So interpretation. So it is mainly it is awareness. If we look at that part, the patient factor about detection, how is their tolerability to oral ion, not checked, because maybe we are thinking that we are busy days, and the patient sometimes they need to be discharged very quickly, so we give the patient the ion and we leave him to go. Okay, we are not usually doing checking about the problem with the absorption, but we find this because the patient is going through ED and then the acute assessment unit, and maybe went to another ward before coming to the GIM. So will be a lot of notes sometimes was missed. The allergy and the counseling about the medication, because we find that some patients they are not taking the ion because of the side effect, the oral iron side effect, mainly the black stool. And this leads them to be, they are not treated for their anemia, so they have the complication. So we have summarized this to mainly we are busy. We have no time, and the load of the iron and the shortage of staff make a big problem for us. And the drug factor, we are also find that this part also mainly about the awareness about the medication, about contraindication, about the monitor. So in this audit, during our discussion with our pharmacist, we find that there is a lot of information missed for us. So I asked them to add some slides added by the pharmacist, which is very interested for us as a medical team to know about this, because just we are prescribing, we don't know about the others. And usually what happened that when we are prescribing the medication, the pharmacists by themselves, they call the nurses, for example, checking about the weight and everything, which was not documented in the system, but they are documented in their record, not our record. Okay, so we can say that mainly our whole problem is awareness as than anything. Asma, anything you can add, please?
You want me أنا بس كنت عايزة أقول حاجة واحدة، طبعًا كان هاتكلم بالعربي mix between. Again, I want to add just if you mix you go for the root cause analysis plus why. If you ask a lot, why, you are going to go to the root cause, because most of what you are saying is related to why it is they are not applying that to them. Like the connection between why there is no that connection between the pharmacist and the medical doctors team. Also, this is maybe now it is a benefit of the audit that it show us this should be in synergetic way, but you don't know about their job or what they are doing, and actually like something more about okay, you say something here about that related to lab or something. I don't remember.
Yeah. Also, because you see, for example, I told you, like, for example, the MCHR, we are not using this. Our practice is just the 6.2, but when we are liaise with hematologists, we find that because the ferritin will not give you the real deficiency. So it will be the best one. Yeah. So also we have to say about awareness again.
I'm just thinking if the laboratory, they are also aware of they do it, or if you ask about it, they are going. Is it available in the lab?
Yeah. I have contact with this. Yeah. I have contact with the hematologists who are usually who are putting the guidelines in the trust. So I find that it is accessible, but we don't know about this. It is accessible and it is not costly, so it can be used. Okay, so that is a good point that we have discovered that we are missing this part, which will be implicated later.
It's just a awareness about the element of the system. Okay. To say also we can add it, and I think also about the training part, about training maybe like a seminar or something, regular seminars, and maybe you can add. This is mainly like a out action, but you can also relate the feedback to the like the pharmacist and the hematologist team. They can tell like in a seminar what they have or something to discuss, and you get more engagement in the team.
Yeah, good point. Yeah, I understand. Yeah, so the action plan, what we have decided after we have analysis all these factors. First, the doctors should consider ordering ferritin transferrin saturation, MCHR, and peripheral blood film and iron deficiency workup. So we have fixed this for our doctor. The other thing that the doctors, when they found the ferritin is high, they have to analyze this in the right context. And before prescribing the medication, now we know that the GI intolerance is important, because if you didn't check for the GI intolerance, you mean that you are wasting your product. You are giving for the person to give him IV, which iron will be needed, and actually there is no superiority between the oral and IV, so it will give the same. Okay, so I think that is why we have to check for the GI tolerability, and the doctor also, they have to calculate the right dose and the full dose according to the weight of the patient and the hemoglobin level, and the doctor should correlate the administration duration to the volume of drug need to be given. And the last thing, that the doctor should document the timing for the second dose, the previous one please, for the second dose in the discharge summary. Because when we are discharging the patient to the community or to his home or to the nursing home, wherever, usually there is discharge summary. And in this discharge summary, we have a part for the GP to follow with the patient. So if we have said to him that the patient received, for example, 1 gram, and he need to have another 500 milligram. So by this, you ensure that the full dose were given to the patient. And usually when the doctors, they are doing the discharge summary, but this discharge summary need to be sent to the pharmacy, and the pharmacist, they have to review all the medication. So we have an action plan between us as a doctor and the pharmacist to double check that this was documented in the discharge summary. Otherwise, the discharge summary should not be be authorized, and the doctor should agree about the second, please, the next asthma. And we have agreed between the nurses that if we have prescribed Ferinject, it should be on the daytime. If there is any complication, it may be dealt, okay, with it early. And the junior doctor should counsel the patient before prescription of Ferinject and the need for compliance to oral iron, if needed to be taken later to avoid the relapse. So we have to talk with the patient. We had tell them that that is a benefit and that is a risk, and at the same time, so we need a maintenance. So whenever you are not taking the medication, and that is a side effect, but you have a relapse for your anemia, and the complication will start, okay, in a vicious circle. So if we educate the patient, we will find ourselves that we are losing the patient and we are increasing their suffering. And the pharmacist need to be confirmed involving to add note on those prescription and the timing of the second dose. That is our recommendation, or our action plan, what we have to do. So we have put a timing for re-audit. It will be like 2 to 3 months after implementation of the changes. And we need to review the same standard prior to re-auditing. And also we have agreed that this presentation should be shared by the pharmacist, the nurses, the nurse manager on the ward. They have to be aware about this, and they have to add for them checklist about how to administer, and how to monitor, and what should be besides the patient, because it's for allergic reaction. Usually when I ask them that what you are doing, they say, okay, we are just observing the patient for 5 minutes, but they never have any anaphylactic kit besides the patient, and they are not monitor the patient after the administration. So we agreed about this plan. Next, please. So I thank This is my consultant and my colleague helped me, but my great thanks to Asma, really, and the course for C, for easy clinical audit, because really it helped me too much to do this audit in very short time, because it was very effective and very accurate in the task what you want to do. So I thank Asma very much to have this opportunity, and I am encouraging anyone really to have no practice with the clinical audit to have at least an introductory with this course. Thank you very much. That is my reference. Yeah, that is my reference. Thank you very much.
Thank you.
Thank you. Any question or anything I can?
أنا عندي questions. عايزة أسألك. عايزة
Okay.
أسألك in term of what in term أنا الأوديت البرزنتيشن ده كنت عايزة المين للفكرة الأساسية إنه الحاجات struggling مثلا، يعني زي دي حتكون الجزء ده part of like إنه نحن بنتكلم عن الحاجات اللي ممكن تكون حاسة إنها struggle بالأول وبعد ذاك عملت شنو عشان تمشي فيها من الفكرة يعني.
والله الحاجة الأولى اللي كانت يعني حسيت إنها فيها struggling، إنه من الأول إنه how to set the standard، لأنه لقيت إنه أنا أي نعم عاوزة أعمل أخذ الستاندر بتاع المستشفى، but at the same time كنت عاوزة أعرف الأوفرفيو بتاع الكلينيكال براكتس overview how is it. مفروض أنا طبعا إني ما أضيف كل المعلومات دي، لكن بس عشان teaching purposes، but I have to find that this is standard, how to find the best standard. That is the one point. Yeah. And another thing that the population size.
كيف الحاجة اللي أنت عملتيها شنو كان يعني I mean إنه أنت هسي قلتي إنه كانت حاجة بالذات حتة الفارماسيست، عشان أنا متذكرة كان بس دايرة to give a tip in this.
هم طبعا لقيت إنه الفارماسيست، لقيت إنه عاملين هم حاولت إني أتناقش مع الفارماسيست وأشوف إنه how they are sticking to these guidelines, what is the standard they are depend on. اكتشفت إنهم عندهم ستاندر مختلف، مختلف، لكن at the same time they have the same conclusion. في النهاية وصلنا إنه الستاندر بتاع المستشفى we have to follow، لكن هم حاولوا إنه بقدر المستطاع نقول الستاندر بتاع المستشفى جاي من عندهم، فشوية كان في conflict في إنه الستاندر to find the standard، كان بالنسبة لي مشكلة كبيرة.
في النهاية I mean إنه أنتوا you follow the guideline from the hospital اللي هي في حاجة الهوسبيتال، اللي هي في النهاية كانت agreement between الفارماسيست والميديكال ستاف is the same.
والهيماتولوجيست، يعني أنا حاولت إنه أعمل connection، حاولت أعمل connection معهم كلهم على أساس إنه the best standard.
Their interest كان في الدوز ولا كان mainly في الدوز sizes؟
في الدوز وفي الانتربريتيشن بتاع اللابوراتوري انفستيجيشن زي ما شفتي، حتى عشان كده انا كنت جبت النايس بتقول الليفل كده، البي اس اتش بتقول الليفل كده، التي سات يعني في some discrepancy changes but at least عندهم حاجات مشتركة مع بعض.
Okay, you go for the المشتركة يعني.
أيوة.
Okay. أيوة. That is all. أي في كان برضو في الكالكوليشن للستاندرز كان في patient مذكرة، بس عايزة to share this with ممكن الناس عشان برضو الناس كتير بتقع لها حاجة زي دي.
أيوة.
بس ممكن تورينا عنها عشان الناس تعرف إنه ممكن في حاجات بسيطة مثلا في الكالكوليشن ممكن زول يكون حاسس إنه واقف فيها، لكن تكون بتستاهل الوقفة دي.
والله صراحة الكالكوليشن أنا كنت حاسبة إنه حاجة صعبة، لكن لقيت إنه يعني ما بيحتاج، يعني شفت الجدول بتاعي فحاجة كانت بسيطة جدا، فجبت الستاندر 100 وشفت أنا كم بيشن، يعني عملته في وورد عادي، عملت كالكوليشن عادية، فما عملت معي حاجة يعني. فكان انت إنه زي ما شفت الجدول كان ريفلكتيف، يعني طلعت منه البرسنت، الألوان عكست لي نحن وين، فما هو حاجة صعبة بالعكس.
البيشنت who die I remember just the point بتاعت patient died وبعدين الكالكوليشن في الحتة دي، بس أنا دايرة أذكر حتة الستاندرز إنه بتقسم على إنه الستاندرز إنه بتقسم very standard.
أيوة ما أنا على حسب إنه طبعا بعد ما حضرنا الكورس في الكالكوليشن أنت بتجيب البيشنت هو ميت الكرايتيريا على البيشن علم الستاندرد ناقص الاكسكلودد نمبر، فالاكسكلودد نمبر دي فعملته فبيشن مثلا وصلنا الدياجنوزيس و everything، لما جينا للادمنستريشن البيشن دايت اوكي، فقمت عملته exclusion criteria. فانا ممكن اعمل لكم شيء اللي هي كانت الكالكوليشن اللي هي استعملتها في الحالات زي دي.
اوكي ايوه دي هي البوينت، انه مرات بيكون الستاندرز في ستاندرز بتاعت الدياجنوزيس تجمع البيشنت اللي هو الاكسكلودينج البيشنت، بعد ذلك بتيجي تعمل له اكسكلوجن من البوبيوليشن كلها if he died اللي هي في الحته بتاعت التريتمنت الليتر لما ظهر في حته التريتمنت. اوكي في سؤال عنده سؤال من الناس، فدوى علي وائل أو something، ما عارفة to pronounce the names. thank you الناس اللي برضو كانوا حضور كلهم، شكرا جزيلا لكم. شكرا يا سارة for sharing this and
شكرا لك يا
wish you
إن
all
شاء
the
الله
luck.
الجميع يعني إن شاء الله أشجعكم إنه يعني الموضوع أي نعم صعب في كده كيسي، لكن مجرد ما تبدو يعني. أنا يمكن أخذت الكورس في كان يوم 18 يا أسماء صح؟ 18 19 أفتكر تقريبا. فيعني الموضوع كله ما أخذ يعني أقل من شهر يعني عشان أخلص الحاجات دي، الداتا تخلصت سريع وحتى البريبريشن كان سهل، فبس إنه يكون عندك جايدنس.
ممتاز.
وأسماء ما قصرت، الله يديها العافية.
تسلمي. يبقى بعد كده بس فضل هي طبعا خطوتين وجست انك يو بريزنت فيدباك للمستشفى دي، تخيلي this step، بعد ذاك منتظرين الري اوديت we are waiting for you ان شاء الله.
إن شاء الله
ان شاء الله. وكل الناس برضه كل الناس الحضور والناس في القناة، أتمنى إن الموضوع يكون بالنسبة لهم easy simple، ما نعقد الأمور. audit المفروض تكون is a habit, is a daily habit in the hospital. Don't complicate it. It's very easy and you can do it. Thank you. باي باي. في زول عنده حاجة؟ مروة أنا ما أعرف إيش ظهرت هسي أو كانت مع باي باي ظهرت لي هسي النيم. باي باي.
باي باي. باي باي.